now move to the restrictive. So we discussed the paralytic. Let's now discuss the restrictive strabismus, starting by one of the most important, if not the most important, restrictive strabismus cases, which is the Duane syndrome. So Duane syndrome, what is the Duane syndrome? Sometimes referred to as Duane retraction syndrome. It is a congenital anomaly in which there is co-contraction of both medial and lateral rectus. And this will result in retraction of the globe on adduction. So there will be retraction of the globe on adduction. So why? Why those both medial rectus and lateral rectus contract together? This may be due to aplasia of the abducent nucleus. So there is no nerve supplying the abducent nucleus, or there is no abducent nucleus. So there is no supply to the lateral rectus by the abducent nerve, resulting in that the lateral rectus will be supplied by aberrant branch from the oculomotor nerve. So imagine now that this patient doesn't have a nerve that supply the lateral rectus, a normal abducent nerve that supplies the lateral rectus. So it is only supplied by a branch coming from the oculomotor nerve. So when the patient is looking medially, the patient will have a problem of that both medial and lateral rectus will contract because both of them are supplied by the oculomotor nerve, leading to retraction of the globe. So this will be the hallmark of Duane syndrome. So what is, let's see this photo here. You can see this patient in the primary positions looks normal. When he looks to the right, it looks normal ocular movement. However, there is a little bit of retraction of the globe. There is like, you see this narrowing with the palpebral fissure on looking to the right. This is a retraction. When the patient is looking to the left, what happens? There is limitation of abduction of the left eye. Limitation of abduction of the left eye. So there is limitation of abduction and retraction of the globe, and this will be characteristic for Duane syndrome. So what are the different types of Duane syndrome? There is type 1, type 2, and type 3. Type 1 is the most common, in which there is normal adduction with the globe is a primary position normal or slightly esotropic, and there is limitation of abduction like this patient. There is limitation of abduction in type 1. In type 2, there is limitation of adduction with normal abduction, and the primary position is ortho or slightly exotropic. While type 3, there is limitation of adduction and abduction, both of them, with the primary position is ortho or slightly esotropic. So how can we remember them? Remember them by number of Ds. If it is only 1D, limitation of abduction, then it is Duane type 1. If it is 2Ds, limitation of adduction, which has 2Ds, then it is type 2. If there is 3Ds, like limitation of adduction and abduction, then it is Duane type 3. Okay? So this will be making it much more easy. What are the pathogenesis and other features of Duane syndrome? So the Duane syndrome will show that on adduction, there is retraction of the globe and the narrowing of the palpebral fissure. This is regardless of the type of Duane. So don't confuse between the type of Duane and the site of the or the direction of gaze, which cause narrowing of the palpebral fissure or retraction of the globe. Whether it is type 1, type 2, or type 3, there will be always narrowing of the palpebral fissure on adduction. Okay? Like this, you can see this is the narrowing of the palpebral fissure on adduction of the right eye. When the patient is abducting, there will be an opening of the palpebral fissure again and the return of the globe into normal position. There could be what's called leash phenomenon. It is upshoot or downshoot on adduction. You can see that the right eye or the Duane syndrome eye will cause either elevation or marked depression on attempted adduction. And this has some theories. I don't want to talk that much about it, but it can be due to slippage of the muscle. It could be that when the patient is looking to adduction, it will cause a slippage of the muscles. So it will cause either elevation or depression of the globe, but it will be just, know the name, it will be just upshoot or downshoot, which is called the brittle leash phenomenon. Very, very, very important association of Duane syndrome is anisometropia. So those patients, if they are amblyopia because of the anisometropia rather than the strabismus. Okay. So usually Duane syndrome doesn't cause amblyopia, but it is the anisometropia. Other associations for those patients, what's called the golden heart syndrome. Golden heart syndrome, it is a facial anomaly characterized by periauricular skin tags, can cause colobomas, can cause high arched palate, facial anomalies, and back anomalies or vertebral column anomalies. Also albinism and Marcus gun jointing phenomenon. Okay, so these are some systemic associations of Duane syndrome. How would we manage Duane syndrome? Now, as a rule, all the restrictive strabismus is managed if in only certain conditions. So we don't manage or we don't treat all patients. We only treat if the eyes are not straight in the primary position, or if there is abnormal head posture, or if there is cosmetically unacceptable upshoot, downshoot, or severe retraction. So these are the main indications. If the patient, the eyes are not straight in the primary position, so the patient complaining of diplopia because his eyes are not straight in the primary position. So our aim is always to make the eyes straight in primary position and in down position. So to make the patient not complaining in the primary position and in the reading position. This is our aim for Duane syndrome and for restrictive strabismus and for concomitant strabismus. We cannot control the movement in, or we cannot improve the gaze in all directions. This is unlike the comitant squint. So bear this in mind. So how can we correct? It is easy if a patient has esotrophic Duane. So it will be the patient has type 1 Duane. We can do medial rectus recession to weaken the medial rectus. If the patient has exotrophic Duane or type 2, we can do lateral rectus recession. So, but for every case of concomitant squint, we said like in esotropia, in infantile esotropia or accommodative esotropia, we used to say we can do recession of one muscle or do resection of the other muscle or do resection for the other muscle. Like for infantile esotropia, we can do medial rectus recession or we can do lateral rectus resection. But can we do the same here in Duane syndrome? This is a very important question. No, we cannot do that. We only do recession in Duane and all restrictive strabismus because the resection will increase the retraction. So the lateral rectus of the affected site should not be resected because the resection will increase the retraction. So if there is significant globe retraction, we can do medial rectus recession and lateral rectus recession, both of them, because the co-contraction of both of them is what will lead to the globe retraction. So if we just do recession for both muscles, this will improve the retraction. Okay. Easy the Duane. Any question in the Duane syndrome? Okay, so this will be the first important restrictive strabismus that we need to understand and know every detail about it. It's a very hot topic in the exams. The second one, which also very important for clinical and for even the Viva and OSCE exams, is the Brown syndrome. So what is the Brown syndrome? A Brown syndrome can be either congenital or acquired, and those patients are characterized by only limitation of action in one direction, which is limitation of elevation in adduction. So when this child is looking to up and left, you can see that the left eye is looking up and left, but the right eye cannot elevate in adduction. This is very characteristic for a child with Brown syndrome or a patient with Brown syndrome. So it can be either Brown syndrome or inferior oblique palsy, as this inferior oblique is a muscle responsible for elevation in adduction. But how can we differentiate? We will come to this later on. So does this patient usually show any strabismus? Usually no. Usually the eyes are orthophoric. There will be only limitation of elevation in adduction, as we can see this in this patient, and also can be present in the primary position. Normal elevation in abduction, no or minimal superior oblique overaction. SOO is superior oblique overaction. There is what's called the positive force reduction test. Force reduction test is a test where we are moving the muscle against resistance, and it is positive in restrictive strabismus and negative in paralytic strabismus. So in Brown syndrome, we do force reduction test. We can find it is positive. If we try to push the muscle by forceps against the resistance or in the elevation and adduction position, there will be resistance. Y pattern exotropia, meaning that there will be exotropia only on the up gaze. Why? The patient, when looking down, no problem. When the patient is looking down, no problem. When the patient is looking up, there will be extortion, or there will be like elevation in abduction of the right eye because of limitation of elevation in adduction. So this will result in what's called a Y pattern. There could be some variable signs such as downshoot in adduction, hypotropia in primary position. So those patients can be either orthophoric or hypotropic. And they can assume a head posture. They will show chin up because they cannot elevate their eyes, so they will elevate their chin. Head turn to the opposite side and head tilt to the same side. So how can we differentiate between the Brown syndrome and the inferior oblique palsy? For the Brown syndrome, usually the eye is orthophoric, while in the inferior oblique palsy, the eye is usually hypotropic. In the Brown syndrome, there is no superior oblique palsy, or sorry, no superior oblique overaction. But for the inferior oblique palsy, there is a superior oblique overaction as a result. So as a result that there is no superior oblique overaction, the pattern will be just a Y pattern. There will be just abduction in elevation. That's it. But for patients with inferior oblique palsy, since that there is superior oblique overaction, this will result in a pattern. There will be abduction, increasing the abduction or increasing the exotropia on down gaze, resulting in a pattern. Positive or force reduction test is positive in the Brown syndrome as any case of restrictive strabismus, and negative in inferior oblique palsy as any case of restrictive strabismus, as any case of paralytic strabismus. The other differential diagnosis will be the monoocular elevation deficit, which will cause failure to elevation of the eye in any position. Dr. Atif, unlikely. Only the V pattern occurs with the superior oblique overaction. So since that there is no Dr. Atif is saying, can Brown causing V pattern? The V pattern is due to inferior oblique overaction. And there is limitation of elevation in adduction. So it will be the reverse. The reverse, that those patients in the V pattern, there is marked elevation in adduction. So how can we manage a patient with Brown syndrome? First of all, treatment of the cause. So it could be a cause. Yes, this Brown syndrome can be congenital or can be acquired. How can it be acquired for patients with rheumatoid arthritis? Those patients have inflammation in different parts in cartilages, especially they can have inflammation in the trochlea. So remember that the superior oblique is hanged over the trochlea. If there is inflammation of the trochlea, this will cause inflammation at the tendon of superior oblique, leading to a restriction of the ocular motility, leading to a restriction of elevation in adduction. So if this is the case, if the patient has rheumatoid arthritis, so in this case, we can do oral or injection of steroids near the trochlea. We can offer presence in acquired cases, and we can do surgery. So surgery is just to do superior oblique weakening. So for those patients, they have a limitation of elevation in adduction. So we want also to limit the depression in adduction, which is the action of superior oblique, to just align the eye in the primary position. And again, this is not in all cases. As any case of restrictive strabismus, this can be done for hypotropia in primary position, abnormal head posture, and if there is any visual symptoms like diplopia. The procedures that can be done to weaken the superior oblique muscle, we can do splitting of the tendon of the superior oblique, or what's called superior oblique tenotomy, or we can do a silicone or superior oblique silicone expander. If there is a short superior oblique, we can do a silicone superior oblique silicone expander, or we can weaken the contralateral muscle, which is the superior rectus. So we do the contralateral superior rectus recession. Okay. So these are the different muscles or different surgeries that can be offered for Brown syndrome. Any question in the Brown? The third important case of restrictive strabismus is the fracture orbital floor. These patients, or those patients with fracture orbital floor, they tend to have limitation of elevation or depression, or both of them. So this patient was subjected to trauma to the right eye. You can see when the patient is looking to the up, there is limitation of elevation of the right eye. There is almost orthophoric on the primary position. And when the patient looks down, there is depression, limitation of depression of the right eye. So this is what happens in the patients with fracture orbital floor. There will be entrapment of ocular tissues within the fracture of the orbital floor. You can see this is the fracture by the CT scan, and this is an extraocular muscle. This is the inferior rectus. So this trapdoor or this fracture will cause entrapment of the extraocular muscles like inferior rectus or inferior oblique. It can cause entrapment of the orbital fat. So it doesn't always have to be entrapment of the muscles, but it will cause entrapment of the ocular tissues. So how can we detect a patient with, or how can we diagnose a patient with fracture orbital floor? First of all, the external signs of trauma. Those patients can have edema, can have ecchymosis, and they have anesthesia along the course of the infraorbital nerve, or lower lid cheeks, side of the nose, upper tip and upper lip, and teeth and gums. This is the course of the infraorbital nerves, which arise from the infraorbital foramen here. So it will supply the side of the nose, the lower part of the cheek. And if there is a trauma, it can involve this nerve. It will cause anesthesia over this part. There will be limitation of elevation or depression, or both of them together. There will be diplopia, and the diplopia can be due to many reasons. It can be due to hemorrhage and edema of the orbital fat. So this will cause restriction of the movement of the muscle, like it is just a contusion, like it is just edema after the trauma, but with no actual entrapment of tissues. So the hemorrhage and edema of the orbital fat can cause restriction of ocular motility, and this will just improve within 1 week. Or it can be due to actual entrapment of the inferior rectus, inferior oblique, or orbital tissues in the fracture, and this will cause diplopia in upgaze and diplopia in downgaze, or what's called double diplopia. Also, those patients can be associated with intraocular hemorrhage, intraocular damage, enophthalmos, which increase in the first 6 months due to orbital degeneration and fibrosis, which will be one of the indication of surgery for those patients. So how can we diagnose a patient with orbital fracture? First of all, the force reduction test. The force reduction test, we can just move the muscle against the resistance by 2 forceps. If we push the muscle inferiorly, we will find the resistance. Another test used to diagnose the fracture orbital floor or in any case of restrictive strabismus, it is called the differential IOP test or differential intraocular pressure test. What is the differential intraocular pressure test? It is we just test the intraocular pressure simply by applanation tonometer in the primary position, and then we compare it when the patient is looking toward the direction of the restriction. So if the patient has restriction in down gaze, we ask the patient to look down and measure the intraocular pressure. If we find there is a difference, like more than 3 or 4, between the primary gaze and down gaze, this will be due to traction of the extraocular muscle over the globe, which will be suggestive of restrictive strabismus. Okay, so if this differential, if these tests improve with time, so this means that it will be just tissue prolapse only. If they persist, then this means it is muscle prolapse. Also, it can be due to direct injury to the extraocular muscle, and diagnosis by negative force reduction test, it will be improving in 2 months due to regeneration. Like if there is no involvement of the extraocular muscles, so there will be negative force reduction test. So what is the treatment for orbital fracture floor? It will be conservative management by, like any case of trauma, by systemic antibiotics and steroids, and ask the patient not to blow his nose to avoid any surgical emphysema, and follow up. And here we come to the important part, is the surgery. So will these patients of orbital fracture floor will need surgery or not? It depends on many factors. The first one is the age. He is old or he is young. But just let's leave this to the end. The second thing is, what is the problem now? Is it diplopia? So the diplopia, as we just mentioned, it can be due to contusion or edema, or it can be due to actual entrapment. So we do a CT scan to diagnose. If it is no entrapment, so we just follow this patient up for 1 week or 2 weeks, the improvement of the edema. If there is indications of surgical interference, we can interfere between 1 week to 2 weeks. What are these indications? It will be a large fracture, more than half of the orbital floor, especially if associated with large medial wall fracture to avoid enophthalmos, or if there is enophthalmos more than 2 millimeters in the first 2 weeks to avoid increasing enophthalmos, or if we did CT and there is obvious entrapment of the inferior rectus by CT scan and confirmed by force reduction test, and there is diplopia of due to limitation of up gaze or down gaze within 30 degrees of fixation or of primary position. So if these indications are present, in this case, we admit the patient for surgical reduction of these entrapped tissues, and we put a mesh in order to prevent further prolapse and close the wound. So the best timing of the surgery is in the first 2 weeks. And the earlier, we can do the earlier surgery if there is significant inferior rectus entrapment. And we can do even much earlier as an emergency in children. For children, there is what's called trapdoor fracture or green stick fracture. What does it mean? So let's say this is a child. This child has a fracture floor, which is a trapdoor. A trapdoor meaning that when he is moving up and down, and the bones in the children are malleable, they are flexible. So this will cause contraction or traction over the inferior rectus and the extraocular muscles as he moves his eyes up and down. They will come in and out through this trapdoor. And this will result in severe stimulation of these extraocular muscles and severe bradycardia, vasovagal attack, and even a heart block or death. Those patients can die from this because of the severe parasympathetic stimulation by the oculocardiac reflex. Do you remember the oculocardiac reflex from physiology? So those patients can have severe oculocardiac reflexes. So if the patient is young with green stick fracture or trapdoor fracture, these patients should be admitted for surgery as soon as possible. So this is a special condition for the fracture orbital floor. Any question in the fracture orbital floor?